Absolutely, yeah. So as I give my presentation, I have some time assigned at the end for questions, but please feel free to ask questions at any time as they arise. I'm going to be teaching from a PowerPoint. I will send that to Deb to share with you all, and then if you have any questions or anything like that, I'll share my email if you think of them after and want to ask. So pelvic organ prolapse in the perinatal population. First, a little bit about me. I've been a pelvic health PT for a little over 10 years. I am a teaching assistant for the Herman and Wallace Institute, which is one of the pelvic floor continuing education groups that teaches PTs how to do pelvic floor PT. I'm an adjunct professor at the University of Central Arkansas because in 2023, I got my PhD in physical therapy in addition to my clinical doctorate. I've done some research in the pelvic floor space. And then I love doing this sort of thing. So doing guest lecturing for like the occupational therapy department, for community individuals, yoga retreats. So I just kind of go and share information with whoever wants information that I have available. So our goals for today are for you to be able to understand how common pelvic organ prolapse is in the general population, and to understand what the long-term health consequences of prolapse can be for your clients. We're going to also look at the key risk factors that are both modifiable and non-modifiable for prolapse. We're going to talk about strategies that you can implement in routine care with your clients to identify prolapse earlier and to help with strategies for management. And then we're also going to talk about some core and pelvic floor strengthening principles for postpartum recovery. So why does pelvic organ prolapse matter? For lots of individuals with prolapse, it's really frightening. They may have never heard about the possibility of pelvic organ prolapse. We're going to go over what prolapse is, how people experience it. But for a lot of women, it's terrifying. They reach down one day to wipe and they feel this bulge and they think, oh my God, what's happening to me? Am I falling apart? Is something going to fall out of my body? So it can really be very distressing to individuals to experience prolapse, especially if they don't understand how common it is and how many women deal with it. The prevalence and severity increase with age, but our anatomical challenges are precipitated frequently by parity. So the more pregnancies we have, the more likely we are to have some issues with prolapse. So we'll talk about why that is from a support perspective of the anatomy. Our lifetime risk for pelvic organ prolapse surgery or urinary incontinence surgery is around 11 to 19% in high-income countries. So it's not a small risk. Lots of individuals undergo surgery to try to manage symptoms of prolapse or symptoms of urinary incontinence or both. So we're going to go over our anatomy first. When we're talking about the anatomy of the pelvic floor, lots of people think about the pelvic floor on its own, but just like everything else in our body, our pelvic floor never functions alone. It's like we always tell kids that there's a knee bone's connected to the hip bone, right? Like that is true. Everything works as part of a system. And when we're talking about the pelvic floor, it's part of a system that manages pressure in the abdomen. So at the base of that pressure management system, we have our pelvic floor or our pelvic diaphragm. At the top of that pressure management system, we have our breathing diaphragm. We have our abdominal wall with transversus abdominis muscles in the front, and then our lumbar multifidi in the back. These pressure management issues are also sometimes why we start seeing an increase in low back pain or abdominal pain as somebody progresses through pregnancy. So it's not always just, yes, things are lengthening, tissue is more lax, but sometimes it's an issue between how this pressure management system is relating to itself. So this is a pelvic floor diagram, and we're looking up from the bottom of the pelvic floor. The skin and hair have been removed from the external genitalia, and on the left side of the screen, we have our superficial pelvic floor. On the right side of the screen, we've removed the superficial pelvic floor, and we're seeing that deep pelvic floor. Each of the muscles have an individual name, and they all work to support the muscles of the pelvic floor and genitourinary function. This will be nicer once you guys have the PDF printout, so you'll be able to see it more easily. So here's a cross-section of the female pelvis. So if we had a woman standing in front of us, we divide her down the middle, open her up like a book. This is what we would see from the belly button down. So we have that abdominal wall in the front, anchoring to the pubic bone. From the pubic bone to the coccyx, we have our pelvic floor, and it's acting as that supportive muscular hammock for our urinary bladder and urethra, our vaginal canal, uterus, cervix, and ovaries, and then our rectum. This is not even a complete map of all of the ligamentous structures that wrap and support the pelvis. So when we're talking about muscles of the pelvic floor supporting our pelvic organs, they're not the only piece of the puzzle that are supporting our pelvic organs. We have a vast network of ligamentous structures that are also supporting our pelvic organs. But ligaments, unlike muscle, cannot necessarily repair if they've been injured or stretched significantly. So when we're talking about some of the risk factors for prolapse, prolonged second stage of labor, an extra large baby, things like that, we're looking at what stress or strain have some of these ligamentous structures been under. And if they are not able to function as well anymore, then the muscle has to come in and pick up some of that literal and metaphorical slack to help support those organs. So, what is pelvic organ prolapse? Pelvic organ prolapse constitutes the descent of an organ down its own canal. So, when we talk about like bladder prolapse, really what we're talking about is something called a cystocele or a rectocele. Celes happen when an organ pushes through a neighboring canal. Uterine prolapse and anal prolapse are really the only two kinds of true prolapse because it's an organ going down its own canal, right? So when we're talking about having that descent of tissue and having that prolapse of tissue, we assess that clinically through the POC-Q system. The POC-Q system is the prolapse quantification system, and it's staged 0 through 4 stages, with 0 being no prolapse. And it's defined by the position of the leading edge of the prolapse relative to the hymen. So that's how we stage the severity of the prolapse. And understanding severity is going to be important because that's going to give you some indicators for prognosis for conservative recovery. So the earlier we can intervene, the less these ligamentous structures are going to continue to be strained, the less they're going to continue to lengthen. At least that's the going theory right now. And so we might have better results than if we wait until the prolapse becomes more severe or more problematic. So here's an example of the staging system. 0 is no prolapse. Everything is situated and seated where it should be typically. This is an example of stage 1. So it's about half the distance to the hymen. Once we get to the level of the hymen, which is that little dotted line there, or a little past it, we're looking at a stage 2 prolapse. And so in some of the studies that I'm going to cite for y'all later, they're going to talk about how inclusion into this study was somebody who had stage 2 prolapse or greater. So that means we're coming down about a centimeter within the level of the hymen to a centimeter on the outside. You don't have to know exactly those measurements, but just having this as a nice eyeball is really handy. And then of course we're talking about individuals with stage 3 and stage 4 prolapse. Those individuals are going to have less success in general with conservative management. Though in my career I have seen individuals with stage 3 prolapse who did really well with pelvic floor physical therapy and became asymptomatic. Did their prolapse go away? No, their prolapse did not fully go away, but the symptoms that they were having, the bulging and heaviness and pain, were well managed, so they didn't feel like they needed to escalate to that next level of care with a surgical intervention. So, how common is prolapse? Shocking to none of you. I bet you encounter this all the time. Stuff in women's health is poorly studied, right? We're understudied, we're under-researched. Pelvic organ prolapse is no different. So we do not have enough data to really fully understand this picture yet, but we're gaining information. So if you read some studies, it'll say 50% of the population has prolapse on evaluation. Some studies will say 60% of the population has prolapse. And that doesn't mean symptomatic prolapse. When we look at individuals who are symptomatic, one study that did a community-based screening of women 25 to 84 years old reported a bulge or protrusion that the women could feel in only 3% of individuals. So wide discrepancies in the literature between what constitutes prolapse anatomically, which is that descent that we can see, versus what constitutes symptomatic and clinically significant prolapse, because they're not always the same thing. Risk rises with increased age and markedly with increased vaginal parity. So the more pregnancies and more vaginal deliveries a person has, the increase their risk for prolapse. Global burden studies show a substantial growth and growing burden of prolapse symptoms due to factors like the global population aging and the number of pregnancies and births. So here's another study that was, again, just all over the place. So if 1% of the population has symptoms or 31% of the population has symptoms, right? It's how we're asking these questions, who's doing the question asking, what population we're asking, because somebody who is 25 is going to be a lot less likely, though not completely impossible to have prolapse symptoms in someone who's like 80. So we have to consider the source of where this information is coming from. Pelvic examination, again, all over the place. Maybe 10% of people have prolapse on physical exam, maybe 50%. What's the problem with assessing for pelvic organ prolapse in a traditional dorsal lithotomy position? Are we, there's no gravity, right? So one of the things that we do frequently in physical therapy is we assess for prolapse in standing. If somebody's like, I feel this when I'm only when I'm standing up, and only at the end of the day, we say, great, let's make your appointment for the end of the day, as late as we can get it, with you standing up, so that we can really see how much descent we're getting from your tissues. And we encourage them to make that same appointment with their care providers too. So if you're wanting to really assess or see if this person's having prolapse, end of the day is going to be better to you than beginning of the day, when that tissue has had time to rest and regain its position overnight. Both exam and symptoms, so that means a person who has clinical symptoms of prolapse and physiological detectable change in station of some of the pelvic organs, between 20 and 65%. Long story short, insufficient research. We need more research dedicated to issues that affect women. But you all know, I'm preaching to the choir. So what are our lifetime risks for pelvic organ prolapse surgery? Again, this can be pretty broad, between 11% lifetime risk for pelvic organ prolapse or urinary incontinence to, 7% for pelvic organ prolapse alone. The U.S. has a pretty hard time doing these longer cohort trackings compared to some of the countries with socialized medicine, where they do actually quite a good job of demographic data, where they track a person across the lifespan, because they're interested, right? The socialized medicine system pays for them to have a prolapse surgery, so they want to know how long is this surgery lasting for a person. So in the United Kingdom and in Nordic studies, it looks like the lifetime risk is similar, but that the repeat procedure rate is around 19%. So having a pelvic repair isn't necessarily going to fix everything for that person. It may significantly help symptoms for a lot of people, but just like anything else in medicine, there's rarely a silver bullet. There's really a one-stop solution that's going to just fix everything for everybody. So what are our risk factors for pelvic organ prolapse? When we're looking at non-modifiable risk factors, we're looking at genetics and connective tissue quality. So if you're going to a person's home and you're evaluating them, and you notice they're extremely flexible, right? They're double jointed. That individual may have connective tissue that is more vulnerable to having prolapse. So if we look at folks that are hypermobile, we've got some faces being made. Yes! Perfect segue. Yes, my EDS girlies. Yes, all my people with Ehlers-Danlos, even folks who've never had a pregnancy, they are at higher risk for prolapse, it seems like. So because of connective tissue issues related to hypermobility disorder and or Ehlers-Danlos, because sometimes people don't have a formal diagnosis, they're going to be at greater risk. Increasing age, so as we continue to mature, we have more time for gravity to be working on us, so we have this increase in possibility for prolapse. We already talked about parity. With increasing parity, we have increased risk of prolapse. Obstetric history, we're going to go into that in detail in a second. So what can we help with? What are modifiable contributory factors? The biggest one that we're going to be able to help with is high intra-abdominal pressure activity management. So that canister that we talked about, that abdominal pelvic canister, we're going to make sure that our clients know safe lifting technique and how to manage pressure in their abdomen and pelvis by making sure that they exhale when they exert. So we're never going to be hearing our moms when they're transitioning from sit to stand, that little sound, that's going straight down through the pelvis. We don't want to be doing that. We want to exhale and contract our pelvic floor as we transition. We're also going to be talking about management of constipation and straining to produce bowel movements. That's another significant risk factor for the progression of prolapse. So we're going to talk about good bowel habits with our clients, making sure that they're getting adequate fiber, they're getting adequate fluid in the postpartum period, especially since lactation can increase our risk of constipation because we're now competing for fluid availability. We're going to talk about individuals with chronic cough, making sure that whatever's causing that chronic cough is well managed with their care team. Because chronic cough, again, our diaphragm's at the top, our pelvic organs and pelvic floor at the bottom. So if we have this chronic repetitive coughing, what's that going to do to our ligamentous support over time? It's going to tax that system, right? So we're going to want to make sure that we're working inside the rest of our care team to help manage those symptoms. Heavy manual labor. Sometimes that's modifiable for my folks that come in, sometimes it's not. If it's not, we're going to talk about other strategies and things that we can help support with. If there's somebody who works on a farm, has to lift heavy boxes, has to lift dependent children that are very heavy, things like that. And then of course other risk factors that impact pelvic organ prolapse are going to be mode of delivery, menopausal status, and pregnancy, so like multi-parous pregnancies. Can you guys do twin deliveries? I should know the answer to that.
Texas and Oklahoma.
Yeah, Texas and Oklahoma. Yeah, so just thinking about, again, more pressure on the pelvis with multi-parity. So we're looking at all of this person's risk factors and how their lifestyle interacts with their tissue vulnerability. It's not a one-size-fits-all approach. So when we're looking at a systematic review of the literature, a longer stage, second stage of labor is going to increase our risk for pelvic organ prolapse. Vaginal birth that was associated with levator ani trauma is also going to increase the risk of pelvic organ prolapse. So some people are like, oh, cesarean only. Well, no, cesarean isn't necessarily going to alleviate that risk of pelvic organ prolapse either, because like we talked about, pregnancy itself, just a pregnancy, full-term pregnancy, we're having all of those ligaments pushed to their limits and then they're trying to recoil. So there is evidence that cesarean may reduce some of the risk factors for pelvic organ prolapse, but it's not a fix-all. And as we know, there are all kinds of risk factors associated with cesarean birth separately. Higher birth weight. So the bigger the baby, the more space they need to come out. So that makes sense just intuitively that if we have a bigger baby, the mom had to support that weight throughout the pregnancy and that baby had to exit the pelvis. And then operative vaginal delivery. So if an individual had vacuum assisted or forceps assisted delivery, they're more likely to encounter significant pelvic floor trauma and they're more likely to have pelvic organ prolapse or levator ani avulsion, which is where that pelvic floor muscle can get pulled off the bone. So if that muscle gets pulled off the bone of the pelvic floor, then it's not going to be as effective at being able to contract because it's lost one of its anchor points. So we talked about this already. Compared with spontaneous births, cesarean was associated with 72% lower hazard ratio of pelvic organ prolapse. But of course, cesarean has a much higher rate of morbidity and mortality both for the infant and the mother. So it comes with its own risks. There's no easy way to get a baby out. Operative vaginal births were associated with higher rates of prolapse than spontaneous vaginal births. So if they're having to have forceps or a vacuum extraction, they're going to be more likely to have pelvic organ prolapse. And so I know that some of you end up having clients that this is their second pregnancy and they didn't have maybe the best experience in a hospital-based setting. So these are maybe some things to ask about their previous delivery history. If this is not their first child, did you have instrumented delivery with your first child or second child, depending on when they're seeing you in the course of their reproductive life? That'll give you a hint about what's going on. So here are some images of the different types of pelvic organ prolapse. Cystocele, we said, remember, seals are when things push through the neighboring wall. So I always tell my patients, if we want to think about prolapse, and so that they're not so frightened that their organs are just going to fall out of their vagina, because that's a major, major fear that a lot of gals have. I tell them, put your finger in your pocket and then just push your fingertips through the edge of your pocket. You can see the bulge from your fingertips, but your fingers can't come out of the pocket. You just see the pressure where it's pushing into that tissue, just as a way to tone down the fear associated with some of these anatomical changes. So when we have a cystocele, we have that edge of the bladder pushing down into the vaginal canal. When we have a rectocele, we have the rectum pushing into the posterior wall of the vaginal canal. When you're looking at a vaginal canal, if you see something at that introitus, we don't really have a way to know which compartment we're having bulge down and out until you palpate it with a finger, because it could be that you're seeing the anterior wall, it could be that you're seeing the posterior wall. With the vaginal wall, it's easier to see because you sometimes can visualize the cervix. But same thing with palpation. If you palpate and you feel that pressure like you're palpating the end of a nose, you're in contact with the cervix. Enteroceles occur when the small bowel is pushing into the vagina. Again, you're not going to be able to necessarily tell, is this an enterocele, is this a rectocele? They will start having other complaints or complications that just are kind of unusual, more bowel cramping, more discomfort. We see enteroceles not commonly, but it's also not that infrequent. We probably have like 3 or 4 people a year that we're like, this isn't progressing as usual. Can we get you evaluated further by your doctor? Usually a colorectal doctor or GI doctor. And then of course, uterine prolapse. This is a true prolapse where the uterus is coming down its own canal. It's coming down the vaginal canal. And then vaginal vault prolapse is most common post-hysterectomy. So hysterectomy isn't even necessarily a fix-all for prolapse. You can still have loss of that connective tissue support after having a hysterectomy, and the vaginal cuff can involute. So, what are our symptoms of POP? Our symptoms of prolapse. Our gals are going to say they feel heavy, they have this sensation of pressure in the perineum. They may say, I feel like I have like a full tampon in, or they might say that they have difficulty emptying their bowel or bladder because of an obstruction, but if they put a finger into the vaginal canal, it empties more easily because they're splinting. They may have low back or abdominal discomfort or aching because those ligaments are getting pulled on, it doesn't feel good. Or they may just feel like their organs are falling out. But remember, lots of individuals that have prolapse have no symptoms. They're completely asymptomatic. So having the descent does not equal prolapse symptoms. You'll see some individuals who are like, wow, this is a really mild prolapse, grade 1, grade 2, but their symptoms are driving them nuts. It's very severe for them. And then you may see other individuals who have a grade 3, they're not symptomatic at all. So, what are some things that you can do to screen for potential progression for pelvic organ prolapse? We talked about the POP-Q. These POP-Q sticks, which look a lot like popsicle sticks, you can get. We have them in our clinic. We get them from CMC Medical. And in some of the research, the distance between the urethra and that posterior vaginal fourchette is the measure that's called the genital hiatus. And so the genital hiatus, as it gets larger, they have a higher likelihood of having pelvic organ prolapse. And it's a really easy measure to do. So if we have a genital hiatus that's greater than 3.5 centimeters, that individual is at higher risk for pelvic organ prolapse. So that may cue you in when you're doing a postpartum evaluation, like, hey, let's just get my little popsicle stick out. Let's see how much space there is between the urethra and the posterior fourchette. My little popsicle stick, my PopQ measure, and see how much space there is. And if I need to coach this person of, hey, this may increase your risk, we can do a lot of things now to manage that and get ahead of things.
Can you do that with a tape measure?
You could. We do this just because we put it up against the tissue, like it's touching their skin. And so just for hygiene, we just use these disposable popsicle sticks so that it's one and done and it's very easy. You don't have to, and they're super cheap. So you could do it with a tape measure. It's just because we're actually like pressed into the tissue to get at the urethral meatus and at the posterior fourchette. It would just be
What word are you saying?
fourchette, the posterior fourchette. So it's this section right here, that fork, it just means posterior fork. So if you think about the vaginal opening, the vaginal canal, that bottom edge of the vaginal canal where it comes to that sort of point, that is that posterior fourchette. Just means forking.
Is the measurement more accurate postpartum or is it accurate during pregnancy as well?
You know, I don't know if the literature has evaluated like when is the best time to measure. So I think what I would do is take a pre-delivery measurement to get their baseline and then do a postpartum reassessment maybe at like 6 to 8 weeks and just see like how much of a change there was. I think that would be interesting to do, but I don't think there's any like data that's saying we have to do it now, I have to do it at this point. That'd be a great thing to check out to study.
So this is just an anatomical issue of how far it is from one to the other.
Yes, how far it is from the one to the other, because that distance can actually be reduced with pelvic floor exercise. So if we have more tissue laxity, then we have a greater opening for those organs to descend.
But it's already just, some women just have.
Some women
they're
just,
built that way.
some women are just built that way. And so, you know, we talked about those non-modifiable risk factors where some gals anatomically have just, they're built in such a way that they may be at a little bit higher risk. So, yes. And again, knowing your risk allows you to make changes in terms of really staying on top of your constipation and straining. You know, educating that person like, hey, you have this increased risk factor. That doesn't mean you're going to have symptoms. It doesn't mean you're absolutely going to have prolapse, but you're at a little bit of greater risk. So we want to do things to take care of you and to help make sure that you know to manage so that you can manage your risk. Yeah, you're absolutely right. Normal anatomical diastasis recti is like that too, right? Like I just have a really wide linea alba. I've never had a pregnancy, but I have like a diastasis with linea alba depending on which study you cite. Do I really have a diastasis? No, I just have a really wide linea alba at my belly button. Just one of those anatomical factors.
So they're at more risk if they're over
3.5 centimeters.
Over 3.5.
Yes, and then there's another measure from another study where they did the genital hiatus measure and the perineal body measure. So they added those two together. The perineal body measure goes from the posterior fourchette to the leading edge of the anus. That's how long their perineal body is. And if their genital hiatus plus their perineal body was more than 8.5 centimeters, that was indicative of a potential levator avulsion. So that's where we talked about that muscle may have popped off the bone. And that's important for us to know because that's going to increase their risk of prolapse in the future.
Did you say we're gonna get these
You can
slides?
Yes, I will send the slides to Deb and she can
Email them?
disseminate them. Yeah.
What's that?